Hi, in this episode of Psychiatry in 5 Minutes, we're going to be going over dementia. There's a lot to cover, so I apologize. This one, too, will be a little bit more than 5 minutes. So first of all, what is dementia? Dementia is chronic brain failure. That is, your brain is failing to do what it could before. It's memory failure, but it's also speech failure, thinking failure, and behavior failure that all goes in together. When somebody presents with brain failure, often it's memory and speech problems we see first. What do you do? Most importantly, get a history. And this is best gotten from family members because the patient doesn't remember by definition. So how long has this been going on? What have they noticed? Has the progression been gradual or sudden? A patient that has a gradual progression of problems is typically Alzheimer's disease. Somebody who's going along and then has a sudden drop, that would typically be due to a stroke or delirium. And so you look for the history of what's going on, and that's most important. Next, after you get the history, it's important to do some type of cognitive screen, MoCA, Mini-Mental, SLUMS, the Mini-Cog, or some sort of cognitive screen. I think that is the most neglected area that we see in clinical practice. You need to do some type of cognitive screen. Next, you do lab tests to look for reversible causes of cognitive problems. In other words, do a CBC chemistry studies, including renal, glucose, LFTs, do a thyroid function study, TSH at very least. In addition to that, it's helpful to do urinalysis. People debate whether checking B12 folate and RPR is useful because they usually are not helpful. But to be complete, it's not a bad idea to do it. People who present with cognitive problems at a young age, an HIV test is never a bad idea. And then you do some sort of brain imaging, usually CT or MRI, usually MRI just because it gives a better picture. Okay, so let's talk about Alzheimer's disease first. Alzheimer's disease is a disease where there is a gradual deterioration. Typically, a patient comes to you after they've had the disorder for 2 years. And so there is an ongoing process which has been going on for some time. Dr. Alzheimer, when he described the disease more than 100 years ago, described plaques and tangles that he saw in the brain of his patient. We now know that the plaques contain beta amyloid and the tangles contain twisted neurons or tau protein, TAU protein. Now, there's an ongoing debate which has been going on for a long time whether Alzheimer's disease is, in fact, accumulation of beta amyloid or accumulation of tau, or if the accumulation of beta amyloid or tau is simply the result of the disease process. In other words, a waste product of what the disease actually is. I can tell you that for the last 2 decades, we've tried to knock down beta amyloid. It hasn't resulted in anything that's been helpful. So what do we use for treatment for medication? The cholinesterase inhibitors are used first. Donepezil is usually used first. Galantamine is also popular. What you do for all of them, you start at a low dose and gradually go up. The reason you start at low dose is that stomach upset can be a problem. Donepezil is also helpful for the behavior problems that go along with Alzheimer's disease, so it's a good thing to do. Memantine, which is a low affinity NMDA receptor antagonist, is used also in moderate to severe dementia. So how long do you continue these medications? You ask the family. What these medications do most of the time is prolong the course of the dementia. So you ask the family, is prolonging this a good idea? If they say yes, continue. If they say no, it's awful, Dad would never want to live like this, then stop it. Know that if you stop the medication, sometimes the disease progression can be quite rapid. They can fall off the cliff in that way as well. Aduhelm or aducanumab is available, but I don't know anybody who's prescribing it. It's costly, can cause brain swelling and bleeding. I haven't given it to anybody. So, in addition to that, in Alzheimer's disease, there's another approach that is to try to prevent it from happening in the first place. And to prevent it, think what's heart healthy is brain healthy. So, anything that is heart healthy will help. That is keeping your glucose, your blood pressure, your cholesterol in check. Exercise is helpful. And also, depression can lead to an increased risk of Alzheimer's disease. So any type of ongoing support for people would be helpful. In addition, sensory input, put your hearing aid in, glasses can be helpful. At the end of life, meet with families and plan ahead. Know that they should be deciding whatever the relative who has the disease would have wanted, not what they want, but what the patient would have wanted. Sometimes I say, if 10 years ago you were sitting at the kitchen table and you said, Dad, 10 years from now I have to make a decision. Here's the story. You're very ill with Alzheimer's disease. This is what you can do. This is what you can't do. What should we do? Whatever Dad would have told you at the kitchen table 10 years ago is what you do. Now, there's other types of dementing illnesses as well. Vascular dementia is dementia from stroke, and the treatment for that is aspirin or plavix. You can also give a cholinesterase inhibitor. Lewy body dementia is also a common form of dementia, and that is presents with a triad of dementia, often prominent visual hallucinations. People may describe little people running around on their desk, and it has a fluctuating course. Do not use high-potency antipsychotics to treat this. Use low-potency agents like quetiapine, but remember that the antipsychotics are associated with an increased risk of death in dementia, so always get permission from next of kin or the family. Parkinson's disease is associated with dementia about 40% of the time or more, but remember that it is a very slowly progressive dementia, and so people often have the disease for more than a decade while you're following them along. Normal pressure hydrocephalus can also cause dementia. Here you have a triad of dementia, gait disturbance, and incontinence. If it's acute onset, the treatment is a shunt to drain the fluid off of the brain, but it's not without risk, so again, talk with family members about it. Alcohol-related dementia, or Korsakoff's disease, is caused by chronic thiamine deficiency. If you catch it, somebody's cognitive decline should stop and they should even out. And that can be a way of treating dementia, even though you can't prevent it. Okay, so behavior problems also occur in dementing illnesses, and agitation or outright psychotic behavior can occur, that is, hallucinations and delusions. To treat this, people usually use behavioral approaches, that is, to try to avoid situations where the patient would get upset. Remember, behavioral approaches in dementia means we change our behavior to fit them, not the other way around. If that doesn't work, trazodone is often tried. If that doesn't work, boy, then you go on to the antipsychotics. But remember again, antipsychotics are associated with an increased risk of death. They should already be on donepezil, and donepezil can be helpful in behavior problems. Finally, let's talk about mild cognitive impairment. And mild cognitive impairment is not a severe dementia, but by definition mild. Someone has memory trouble, but not problems with their ADLs. They can dress, they often can drive without difficulties, so it's memory trouble. Donepezil is not really helpful for mild cognitive impairment. Well, how often will they go on to Alzheimer's disease? And about 10% of people per year will go on to Alzheimer's disease. In other words, about half of them will develop Alzheimer's disease in 5 years. So anyhow, I hope you read more about dementia, and I apologize that this was a long description. Thank you.